Obtaining warfarin and INR orders in assisted living setting, a performance improvement project. This initiative occurred within a community care setting which has the peculiarity of being a home-like environment in which medical orders cannot be implemented without residents' agreement, and still our facilities are state regulated and thus subject to certain standards and expectations of care. The project was started because repeated problems were identified with obtaining timely or complete warfarin and INR orders for the residents in our community. The reasons for these difficulties are diverse, and they include reasons like having different ordering providers and diverse provider settings to deal with, which include MD clinics, various anticoagulation clinics, hospitals, house calling nurse practitioner, hospice, or dealing with particular health care systems like the VA or the Kaiser system. There are also varying degrees of facility staff involvement in the management of INR, ranging from having to do most steps to just updating orders and administering the medications in some cases. And thus the staff also has various degrees of control over the process, but the entire control ability is limited by the fact that the ordering providers are all outside of our setting. There are also individual resident responses to medications and to clinical conditions to be considered, including their own medication changes that may happen being sick, or diet changes which we are not even aware of. And the fact that the assisted living facility is a home-like environment where the diets are uncontrollable by the staff as well as are the residents' actions. The residential care facility, which is adjacent, is slightly more controlled because of the way it's set up as a secure unit, but still it is very liberal in terms of choices for the residents, which have to be respected in our facilities. Part of the limitation includes the fact that unlicensed staff is providing direct care in the facility, and most of them are lacking the deep clinical knowledge required to understand the importance of certain lab values or the urgency of certain orders needed. The staff is also dependent on the lab providing timely results, which have to be forwarded to the providers, and also on the providers responding timely to the requests for orders. There are numerous communication issues with the clinics and provider offices. For example, calls taken at clinics by personnel who seem to not be always well trained or versed in medical terminology, conditions and treatments, or not understanding well the importance of a message or request. Also the fact that the doctors are unavailable most of the times to directly discuss care or issue an order by phone. And often there are fax issues which we find out about later on, as it seems the faxes are not always working on either side. Then there are multiple prescribing providers which do not communicate with each other. For example, a primary care provider ordering antibiotics where the cardiologist or anticoagulation clinic prescribes the warfarin. And a great part of the facilities staff duties are the coordination of care for our residents. The final objective of this performance improvement project was to improve the ability of facility staff in community-based care, may it be the assisted living or the residential care facility, to obtain new and timely orders from the ordering providers for both the warfarin weekly dosage as well the next INR check due date, which said to report has been sometimes missing on new orders. And this is meant to be done for the residents who have anticoagulation plans using warfarin. And the intent was to simplify the process used by staff to obtain this INR and warfarin orders. This is all occurring on the background of regulations to which our facilities are subject to, in which the staff need written orders upon which to act, as they are unlicensed staff, and there's also the limitation that they cannot take verbal orders directly from a provider, and the nurse is not present 24/7 in the facility to do so. There were 3 types of project participants involved in this improvement attempt, and they all have an important share to the success of this project. The direct care staff are the ones who actually pointed out initially the need for such an improvement initiative, as they reported having difficulty obtaining orders, at least doing so timely, and they provided a lot of initial feedback on how the process for obtaining warfarin orders is happening for each of the residents. The med-aides are the ones dealing with daily processes of care, including forwarding lab results, expecting and receiving orders from providers, implementing them via entry in the electronic record system and administering medications, monitoring the residents with INR values out of range or with any changes noted, following up with providers when orders are missing, and advocating for resident needs. It can be frustrating trying to provide care and then being practically at the whim and mercy of other agents in this attempt to provide quality care. The med-aides are also the initial direct users and ongoing reviewers of the new tool proposed as an intervention for this project, and they are the initial monitors of outcomes. The project included all med-aides by default because as soon as the project was started, everybody was required to use the new tool. However, there was stronger involvement by the lead med-aide or health coordinator, as they are called in our facility, to avoid confusion with the licensed medication aides. And one of the med-aides volunteering who works a split shift. That means she works 4 hours in the morning and 4 hours in the evening to help cover heavy pastimes. And their involvement included suggestions for the tool design. The facility supervisors were the project initiators. In our company's community-based care setting, the RN, Director of Health Services, is overall responsible for guiding and improving the health services. Staff training and education are a big portion of that, as well as quality control processes. The nurses are the ones that are triple checking paperwork, including new orders, and who are bringing the clinical knowledge and insight to care processes needed to ensure safety of the residents. And they are there to provide guidance to the unlicensed personnel in situations where they may lack the needed clinical knowledge. The nurses are also being involved by system default in obtaining or pursuing orders in cases when delays or difficulties with outside provider offices are noted. For example, no response to a request to respond to an INR lab result. And thus the nurses may gain a larger overall perspective of what is going on both inside our facility as well as at outside provider offices during this process. The suggestion for this tool came from myself, at the time the Director of Health Services of the building. The project was approved by the ED, administrator of the facility, and by our regional director of operations without issues. As supervisors, part of the duties do include data collection and processing for other quality improvement and quality control processes. So doing so for this project was easy and just a small task to add on top of the rest. The design of the tool was based off on the Warfarin orders page we used to receive for a certain resident who has passed in the last year, and those orders were coming from an anticoagulation clinic which no other resident is currently using. Those printouts were very clear and easy to read for the med aids, and thus some of the structure was adopted for the new tool. As the Director of Health Services over almost 2 years, I was the one holding this knowledge. The community nurse is more new to the position. She has started her position in January this year, so she would have not had access to this knowledge. The nurses and the resident care coordinator, who is mainly involved with audits of care, gathered the initial data and noticed the trends and the need for improvement. Designing the tool was a team process with input from all stakeholders involved, but ultimately completed by the nurses. Implementation of use and education on the issue was also provided by both nurses at monthly med-aid training meetings and on individual basis as needed. Data collection was done to adjust the process, which also happened during the entire intervention, and it led to actually changing the tool once to providing reinforcement of teachings as needed to the staff, and contacting provider offices to make sure the new tool is well received and useful. The outside providers are an important factor in making this intervention successful. However, their contribution was also the least controllable part of the process, and in retrospective, it could not be changed significantly on all points attempted in some cases, which included mainly MD clinics. The outside providers involved in this project included 3 doctors, 2 of which manage the warfarin for 3 of our assisted living residents who are enrolled for care at the same office. It also included pharmaceutical doctors at 3 anticoagulation clinics, 1 house calling nurse practitioner who is managing 2 of our memory care residential care facility residents, and as I've said, the greatest challenges we have had and continue to have partially are with the MD clinics, offices, which do seem to be strongly affected by the setup they have and the quality of their office staff. In order to be able to evaluate the effectiveness of our intervention, the following methods were used. Prospective and retrospective data collection for approximately similar amounts of time were done via review of the electronic health record system, review of paper charts for each resident involved. As a side note, our facility still needs to have valid signed orders, which still forces us to use a lot of paper, which ends up in binders, which constitute the paper portion of the resident chart. Doing retrospective data collection was limited due to the purging process, which happens every quarter to help control otherwise insane amounts of paperwork. It also was limited in terms of data we were able to collect. In some instances, we could not determine if orders had been obtained timely, or if not quite timely, how many interventions and trials it may have taken in certain situations to obtain full orders. Prospective data collection, however, rendered better data, which was likely also due to the nurses' triple check process of paperwork. So our prospective data is more complete and accurate than it was possible to do with the retrospective data. There is still a further need to evaluate data going forward and using the same methods to be able to actually identify better differences made by this intervention. Data obtained was then analyzed in terms of comparing effects of the intervention in improving following indicators. First, the timeliness and the accuracy or completeness of new orders received. Like I said, part of our issue was that we were missing often a next INR due date, which is actually significant if you want to provide good INR monitoring. And also the other indicator was to see if INR values are better controlled after the intervention. I have used odds ratios or risk ratios to report the outcomes and changes noted in the chosen indicators. We have also sought and obtained qualitative feedback on the use of this new tool, both by the staff and the providers who got to use it. This was obtained by various methods like interviews, phone calls, informal exchanges, and in one case, a survey response. Most providers actually did not respond to the survey letter sent out, or did not respond timely enough for this analysis. As I said, the intervention was actually inspired by the format of orders for a former resident, which was coming from an anticoagulation clinic we are not working together at this time with. And the goal I had with this project was to create a simple, easy to use tool which would cover most needs we have in this area. So basically create a single page communication form with the goals to ensure clear and complete orders of warfarin for the entire week being sent to the community. Also ensure obtaining the next due date for an INR check, which sometimes was being omitted or forgotten by providers, and then staff had to perform additional steps and work to be able to obtain a complete order. Also, this tool was meant to communicate pertinent, essential information to ordering providers, which really may be crucial when ordering warfarin or adjusting those orders. I was also trying to standardize the procedure used by facility staff for communicating INR results and requesting new orders from providers, which initially was a pretty standard approach of forwarding lab results and requesting new orders, but then depending on various provider responses and incomplete orders, led to the med-aids having to write themselves all kind of messages on fax papers which may not have been fully clear to the providers, or in the end still not lead to full orders being received timely. And final goal which was attempted with this intervention was to improve the provider response times and facilitate getting complete full orders for both warfarin and INR checks with less staff efforts involved. So this is what came out of our work together. I have provided both a master copy of the final intervention tool, as well the example sheet I have created for the purpose of training the med-aids in the proper use of this tool, and pointing out some of the crucial items to fill in or to be aware of that they may be important when ordering warfarin. This tool had to be modified about 1 week into the intervention by adding the ABX used component, where we list the full order for an antibiotic used within usually the last 2 weeks, or at least since the last INR was checked, to trigger the provider to be aware of possible changes in INR or reasons why the INR may be out of range. And this came about because of one resident's case who, just before we implemented this tool, was ordered to use antibiotics by her dentist, at which point the cardiologist office was notified multiple times and repeatedly asked via faxes and phone call to please reorder an INR check due to the use of antibiotics. However, the MD office did not respond, and then upon doing the previously ordered INR check, the resident's value was found to be slightly high, luckily not in the critical area, and no adverse events were noted. This really made it clear that we need to make it obvious to providers that antibiotics have been used, as they are often responsible for huge changes in INR values. And the med-aids have also been instructed that this INR warfarin order request sheet can actually be used to just notify a provider of the possible need to order a sooner INR check by filling out the current order. Sometimes the providers like having all the information together, as it is apparently difficult for them to gather in their own office. And then by pointing out that there have been antibiotics used, or by explaining if any doses were missed or held per orders. So after using this tool for 10 weeks, we performed an analysis of the effects of the intervention. And I did this as apparently I was the most versed person in using statistics procedures from the entire team, thanks to my current statistics course. And I have done this by calculating odds ratios for the data collected. Not all odds could be calculated for the retrospective data accurately, because we were missing in some cases the entire data on how many interactions and of what type exactly were required to obtain full orders in some cases in the past. Even if the delay in getting the orders could actually be tracked for Warfarin orders received only at the time. The statistical work can be viewed in the Microsoft Excel appendage to this post. So what the data actually showed was that, at least so far, missing INR draw orders were reduced to new cases when the new tool was used. The chance of receiving complete orders upon a first trial was increased by 5.72 times per patient day, or by 7.378 times per INR draw ordered, and the lab result forwarded to the provider. Overall, using the new tool led to an improvement in getting both timely and complete INR Warfarin orders of an odds ratio of 1.129. However, there remains room for improvement, as the rate of success upon first request after the intervention was 64.1%, compared to the 56.75% before. We would like to see numbers closing in to 100%, but this is highly dependent on provider office response as well, which is a huge part which we cannot control much. Due to extraordinary circumstances noted within the 10 trial weeks, and due to a small sample data, having 39 INR draws done in 10 weeks versus 37 INR checks in 12 weeks, further data collection and results analysis is indicated to better establish if this intervention is effective and how effective it is. The hope is it will continue to slowly improve our care. So then I analyzed the results specifically for the two indicators we were looking for. One of them being how well was INR controlled with the new intervention. As current research within the USA shows, Warfarin is challenging to use given its narrow therapeutic range, high interpatient variability in response, numerous drug and food interactions, requirement for continual lab monitoring, and in other home settings, the risk of non-adherence to therapy. In our specific community-based setting, may it be the assisted living or the residential care facility, The additional challenge of having reduced mobility, high-cost medical transportation needs, advancing dementia, and also the right of residents to refuse cares or to refuse miss appointments was an issue noted. And facility staff are only able to make recommendations to encourage best practice, but they cannot enforce medical care as it is possible in other care settings like a hospital or a nursing home. So what we noticed was a small reduction in the occurrence of INR values out of range, from 29.73% of results out of range in the previous quarters to 25.64% of INR values out of range in the 10 weeks after the intervention. The odds ratio was 1.16, not a huge change. Part of this success is definitely the trigger to include INR check dates as well as the additional information on antibiotics use that we provided to the ordering providers, which has possibly actually triggered changes in orders or ordering faster an INR due date. So we could avoid staying out of range for longer times. I must also say that we actually have not experienced any critical high INR values this entire year or any severe adverse events from warfarin use were noted this year, which is a good thing. But further evaluation of a larger data sample is needed to confirm the results obtained, and definitely improvement of the time spent within therapeutic range recommended is highly desired. However, from reviewing research on INR management in long-term care facilities, our results are comparable to national rates, which actually means the whole nation has to further improve on the issues of safe anticoagulation using warfarin, something which probably could be improved by changing practices and by using more new technology available, like point of care testing, including in the home environment, and also a change in the practices of some ordering providers. Doing this project also led to some observations which are not absolutely part of the statistical analysis, but are part of the reality of care and have to be considered and addressed when planning for better care. So we all know the old wisdom that old habits die hard, and it was proven true. The staff still continue to see a pattern of some delayed responses from certain medical providers' offices where there's doctors managing the warfarin and INR orders for free of our assisted living residents, which kind of helps skew results. And after directly conversing with two of the doctors and with one nurse at another provider's office, there still remains apparently a huge technical issue with fax transmission and reception to be fixed. And if you are asking why we are using this antiquated approach, it's mainly because of HIPAA requirements and concerns for protecting private information, and all within a care setting where written signed provider orders are legally required. So we are at this time somehow forced to keep using the fax, but have a lot of problems with it. The other thing noted, which does provide some food for thought, is that in the cases where there was independent or family assisted INR management, for example via visits to the anticoagulation clinic, appears to yield better results than pure in-facility management. And this is all likely due to the fact that by doing this, we are cutting the facility staff as middlemen out. They don't have to intervene by faxing lab results to a provider and then requesting orders and then push for those providers to answer, because the anticoagulation clinics issue orders on the spot, and those orders are being brought back by the families or by the residents themselves, and the staff only has to implement them. And overall research does indicate that patient involvement in care is beneficial and has been proven to yield better results than just provider efforts. The biggest issue that could use improvement that we noted was continuity of care, which remains one of the biggest challenges of care today. Mainly, if there are frequent changes in the ordering providers or in the anticoagulation clinic rules, like they may suddenly not accept outside lab results and require residents to go in to test in their own facilities, or transitions in who is helping manage the INR, including for example involvement of outside agencies like possibly home health. These all appear to increase the risk of the INR being out of range. And if you look at the Excel sheet with the individual data, there is one resident there who has been clearly often out of range during the intervention period as well as before, because she has a propensity for INR not to be well controlled. But in her case, during the analysis period, the challenges to care were mainly that within the 8 weeks she transitioned from staff fully managing her entire warfarin and INR orders by coordinating with an outside lab, to the home health nurse who got on board for wound care being also ordered to check the INR values in facility, and then she was the one transmitting that value to the anticoagulation clinic, who was then issuing orders to the facility. And then home health being dropped, and the care transitioning back to staff. And at that point we had a one-time miss on getting timely orders for the next INR due check, because the VA anticoagulation clinic actually failed to communicate the next INR due date to the facility on their orders, thinking that home health would still be involved and do them the next time. As a conclusion of our quantitative data analysis, we have noted a small improvement in both the indicators analyzed with our intervention. Slightly better timeliness and completeness of response received from a provider who is ordering warfarin and managing INR. The odds ratio was 1.129, as well as improved INR control and slightly reduced risk for harm for our residents. The odds ratio was 1.16. And while there is no data on order timeliness in similar settings that I could find, our results for INR control are comparable to values obtained across the USA for patients residing in either own homes or in long-term care facilities. But as mentioned, these indicators do need overall further improvement. For example, the article by CEOs looked at INRs being out of range from the time of 1998 to 2008, and they found that only 57% of times patients were within therapeutic range. Nidecker noted for the period of 1985 to 2010 an even lower mean time in range of only 48%. But reports on post-intervention rates in some studies done to up to 69% with electronic decision support systems in place, or even up to 85% of time spent in range when the INR was managed by nurse practitioners. Samer noted an overall 58.38% in range time for INR values assessed, and Gurvitz noticed that in nursing homes only 49.6% of values were in range over the time assessed. Other studies that were not cited here overall report somewhere around 60% of INR values being in therapeutic range in the USA when it comes to observational data or data collected in the community. Thus, as I have said, improving on those indicators even outside of facility remains a challenge. We also know that from having a small sample and unequal data collection methods for the before and after intervention periods, as well as having some unpredictable changes in the circumstances in our assisted living setting, may render some inaccurate results and faulty conclusions. And I mean inaccurate and faulty to the negative for the intervention, which may have otherwise possibly shown slightly better. And these changes involved having a new inexperienced employee work in the prospective data collection period. After the whole rest of the year, we actually did not have to hire a new med aid, so we had experienced med aids, the last which had been hired in the 2015 fall. And then we also had this previously mentioned outstanding case of frequent transition of care for one resident on the background of having previous high propensity for uncontrolled INR, and this may have also slightly skewed results. Her example is actually one of the cases which makes the argument for changes in practice and trying to use different attempts, because by now, because of her uncontrolled INR, she was actually placed an IV port for INR draws, and she has to use high cost medical transport for trips to the clinic drawing her blood for INR results. And my hope is that such situations could be avoided for patients with a change in regulations and in care practices to include POC testing, including INR machines, which are already available, and possibly systems of direct downloading of data to providers, using direct provider order entry to help avoid errors, using clinical decision support systems for issuing INR and Warfarin orders, or changes in communication tools used, and I mean the fax, which we are having ongoing issues with. Also, further data collection and analysis is warranted, as well as continued actions by the entire healthcare system to try to improve INR control in both the home and long-term care setting. And because this was an intervention meant to help assist our staff do their work better, we also started a qualitative feedback process, which in the end included everybody involved in the project. We sought this feedback also to be able throughout the project to make adjustments if needed and to improve our tool and be more successful with it. So from the ordering providers, out of 3 doctors, only 2 gave feedback. One via phone interview, which was rather informal and unstructured, as we were discussing resident care as well as mentioning the tool at the time. The other replied to actual survey letters sent out, which largely was apparently ignored by provider offices or has not been returned to us by this time. The doctors expressed liking the tool. They found it easy to read and also fast to fill out, which was an important positive feature for them. They said that the message was clear, so previous requests may not have been as clear as to what the staff needed or expected from the doctor when forwarding lab results alone. Both of them found the antibiotics data very helpful, and one of them expressed appreciation for the efforts to coordinate care for the residents. No negative feedback was received from any of the providers. The VA anticoagulation pharmacist did review the tool positively based off one use only, but apparently per their policies will continue to send VA standardized orders via fax to the facility, and will not use our fax sheet to respond. However, will gladly accept it as great information when providing new orders. The visiting nurse practitioner managing memory care residents appreciated the ease of reviewing resident condition based on this new tool, but she also prefers to continue sending new orders via her own electronic health record system generated summaries, which include both the resident assessment and then the new care plan. No other anticoagulation clinic responded or other provider was involved in the project at this time. The best feedback, and mainly positive feedback, was received from the facility staff. They did state that the tool is simpler and clear and easy to use. They did note that it requires collecting more data up front to be able to fill it out, but because this could be usually done in the time of their own choice, it was still preferred because otherwise they may have had to answer similar questions during high stress, busy times if the providers were calling to ask them. They did note that there is not more writing involved than with previous methods used. However, it looks different, but it was very understandable to all of them. They also felt there was better communication with providers, probably based on answers obtained. And I could also feel some professional pride of the staff, feeling better prepared to answer questions if they arose regarding INR management or warfarin orders from providers. Because in the past, the anticoagulation clinic or the provider office would call usually at the busiest times around 4 something o'clock in the afternoon, when the evening shift med aides were trying to prepare their dinner pass, the second heaviest pass of the day, and the calls were made to request the info, which is by now basically included on the fax sheet, in order to be able to still issue orders within the same day. And of course, the stress of having to answer those questions, as well as breaking up the process of preparing medications, was causing additional difficulty to the staff and put them at higher risk of making potential errors. They also explain that it gives them better overview and it helps them understand better the INR management process and how certain medications and changes tie in together in affecting the INR value. The med aides also came up with the idea of creating master models for each resident of this tool in order to speed up the process of communication with providers, and also to help the new inexperienced staff to better coordinate resident care without having to know or learn all the information required at once. The improvement project team members also reported positively on this initiative. Mainly, there was increased staff autonomy noted, which actually meant less need for nurse involvement. So even though we had to put more work up front into the intervention and creating the sheet and training the staff on its use, this all paid off later and hopefully will continue to pay off by having less cases of needing the nurse to actually intervene and discuss directly the need for orders with the provider office. There also was some satisfaction with the final product after each team member had some input, may it have been to inclusion of some information or just the way the sheet should look, and everybody felt like they got to add to it and has some ownership feeling about this tool created together. However, we had to issue a warning against having outdated master models created for residents if the care changes, and then reinforce the need to look at the electronic health record system and at the most recent paper orders received each time, and also to be aware of possible changes in providers or anticoagulation clinic contact information, resident insurance, or other care particulars. We also had to reinforce and restate the need to update the electronic health record system first, and then only adjust the sheets or masters as needed, which we had to explain they are not to be considered a chart item until they're actually returned as signed orders by a provider. Otherwise, they are just a communication tool for our internal use, basically. And working together on this project created a positive outlook and encouraged all of us to continue wanting to do some quality improvement via small manageable projects, along with hope for more improvement noted with the use of the tool, despite mostly having small changes noted so far. And implementing this tool actually required application of strong and effective transformational leadership early in the process, because after the month of October 2016, I had to turn over the management and close supervision of this project to the building staff, led by the LPN, the community nurse, and the resident care coordinator, because at that time I moved into a new position which requires me to work at various sites, different buildings, with so far only sporadic returns to the building I used to lead. And the entire project was now to be led by the community nurse together with the RCC, as well as the lead med-aid, who helps us reinforce procedures with all the med-aids and helps keep track of order in the medroom. However, I hope there will be a return to this building soon, which is expected to happen with the process of training the new RN, which was hired and who will need to be trained. And though currently the schedules are highly varying at this time due to changing building needs, I'm theoretically expected to return there as RN trainer in a couple of weeks, at which time I can also follow up closer on this performance improvement project and release some of the control over the project to the new Director of Health Services, which I will be training. So anyway, though I had to give over my leadership, the project continued because the ultimate goal with the intervention was to empower the direct care staff to have more control over the process and better outcomes expected even in the absence of the nurse, to simply make care safer in all situations for the residents. And part of my cooperative leadership style has always been to train and empower my employees, to have them reach their best potential and to make them as independent with all their duties as possible, and definitely not be highly dependent on nurse decisions or nurse presence to be able to do safe care. I also have some plans to share the success and the idea, especially because now I have a better opportunity in my new position as floating Director of Health Services, and I intend to carry the knowledge of this experiment to other buildings. And if upon further analysis the project continues to maintain its positive effects, I intend to propose this to the Community-Based Care Standards Committee as a possible change, or at least as an additional tool to be considered to be provided officially to all assisted living buildings within our company. And mainly, one of the biggest achievements with this project was actually being able to live up to the 7 values and the 1 mission statement exposed by our company. And I only listed the last of the 7 values, which actually is the one that made me even choose to get on board with this company at the time I was hired, because it states teamwork, camaraderie, and fun. So it does acknowledge that healthcare is a complex process which needs to be completed as a team, and for the team to be effective, a good relationship and cooperation among team members is needed, and good work cannot be achieved within an atmosphere of dread, of negativism, or otherwise difficult circumstances. So we are attempting to make work fun while taking it very seriously and making it clear to our employees as well. And we definitely did have some fun as a team working on this project and seeing it actually be successful, even though at a small rate. I thank you for watching and for providing any feedback for this small performance improvement project in community-based care, and I wish everyone very happy holidays.